distinguished guests and esteemed healthcare professionals present here. It is with great pleasure that we welcome you all to the scientific session as a part of 6th Isacon Northeast 2024 and 5th Annual Isacon Manipur 2024. We would like to express our sincere gratitude to the expert faculties for accepting our invitation despite the prevailing situation in Manipur. We are privileged to have these experts in the field share their insights, experiences, and expertise with us. Today marks a significant moment as we gather to delve into the intricacies of anesthesia practice, an indispensable field in modern medicine.
For chairing the first session, I would like to invite Professor P. Nishikanta Singh and Professor S. Sharat Singh. Professor P. Nishikanta Singh, he is the patron of ISA State Branch of Manipur, and he has served as the HOD of Regional Institute of Medical Sciences, Imphal. Currently, he is a professor and head of the Department of Anesthesiology, Shija Hospitals. Professor H. Sharat Singh, he is a former president of ISA Manipur, and he is currently the senior professor of Department of Anesthesiology, Regional Institute of Medical Sciences, Imphal. We welcome the respected chairpersons to the stage.
During brain-dead organ donation. And number 3, optimization of the brain-dead potential organ donor in the ICU. As the 3 topics are related, and we will have a discussion after the 3 topics. The first one will be presented by Dr. M. Inat. He is an associate professor in the Department of Anesthesiology and Intensive Care, Difu Medical College, Assam.
Good morning, everyone. Respected chairpersons and the audiences. First of all, I am thankful to the organizers for giving me this opportunity to speak in this prestigious conference. As the theme of this conference is organ preservation and protection. So this topic being selected for me is perioperative organ protection. You see, if we do not protect an organ, then how can we go for organ donation? So perioperative period, this is the period where there is tremendous role of the anesthesiologist to protect the organs so that with others procedures. So this will be my topic of presentations. First, I will describe what is the role of surgical stress in organ protection. Next one is organ protection in terms of cardiac, lung, and renal protection. Though my next topic is renal protection, I will not go in details about this. Now, coming to the organ protections in the perioperative period, if we see the magnitude of the problem in the perioperative period, more than 310 million surgeries is being done all over the world annually. And among these 40 to 50 million in the United States and more than 20 million in Europe, and the estimated mortality is approximately 1 to 4% in less than 30 days per year. As per the WHO guidelines in 2018, more than 8 million people dies in the perioperative period globally every year. And if this goes on increasing, by 2030, it will be the magnitude will be more than 12 million people per year. If we compare the different diseases for which the patient dies in 2000 and 2019, if we compare, that most common cause of death is the ischemic heart disease. And most interestingly, more than 50% of diseases can be prevented, and this mortality is increases if there is any other associated morbidities, and there is of course a huge opportunity for improvement in terms of surgical morbidity and mortality. Now, what are the causes of intraoperative death? The most common cause is bleeding, as we all know. Other causes like perforations of organs or sometimes anesthesia-related mishaps starting from airway, difficult airway up to the drug toxicities. And other least common complications like deep vein thrombosis, urinary infection, pulmonary embolism, and so on. Now, if we see the intraoperative death related to anesthesia is approximately 1 in 10,000 patients, and intraoperative surgical death is 40 in more than in 10,000 patients. And if it is an emergency, the chances are higher, the incidence is higher, approximately 370 out of 10,000 people. Now, what is the reason? What is the cause of this mortality? probably the cause is the surgical stress, and it's becoming a healthcare issues. And probably the surgical stress, we never thought that it's so important, and probably this is the neglected stepchild of the global health. Now, what is this role of this surgical stress in perioperative morbidity and mortality? Once we induce a patient in anesthesia, after the first incision, the stress response begins. That leads to increased sympathetic discharges, that lead to liberations of different catecholamines that, that impacts the body homeostasis, like hyperinflammation, altered coagulation, diminished immune competence, T-cell mobilization, that ultimately lead to multi-organ dysfunction syndrome in terms of involvement of different organs. Now, how do we define this stress response? Stress response is an acute response to one or more breaches of the body's barrier functions, from sterile injuries like incision, excision, manipulation, and pain, and subsequent pathogen invasion in terms of gut bacterial translocation and perioperative wound infection. So there is tremendous role of the drugs that we use in the perioperative period in the maintaining of the homeostasis of this surgical stress. But although we use many of the drugs in the perioperative period, but we cannot completely abolish this stress response. There are different drugs like volatile anesthetics that we use in the perioperative period during induction, other drugs like propofol and remifentanil. Definitely, they do have a multitude of both immunosuppressive and immunoactivating effects.
This is Medanta Hospital where I work. This is a 1,500 bedded hospital where we conduct more than 1,000 renal transplants per year, where we do around 350 liver transplants per year, where we do cardiac transplants, where recently we have started doing the lung transplants. The first renal transplant was done in identical twins because of the scare of rejection. It was only after 10 years when the immunosuppression was established, the renal transplant was more a established entity. And it became a treatment of choice of ESRD patients. Not only it has become a treatment, but also the quality of life was increased significantly. So number of organs required to satisfy the needs of transplantation far exceeds the number of donor organ available. So after the transplantation program becomes successful, it is only we want to increase the number of donors because there are far number of organs which is required. Their demand was more than the supply. Donors could be living donors, could be diseased donors. Diseased donor could be donation after brain death and donation after circulatory death. If we talk about brain dead donors, it was a standard to take the donors less than 50 years of age. But because of the increased demand, we have started taking the expanded criteria donors, like donors above the 60 years of age, when there's less comorbidities or no comorbidities were there, or in 50 to 60 years of age, when the patient having a hypertension or the death was because of cerebrovascular cause or pre-retrieval serum creatinine was more than 1.5, if even two criteria are there, we accept these as a donor. This is when there is initiation of cytokinins, release of cytokinins, when there is immunological activities are there, it causes myocardial suppression, and there is a decreased vascular tone, which results in hypotension and inadequate perfusion of organs. With cellular swelling, there is a lysosomal rupture is there, and there is a death of the cell. So what are the aims of modern kidney storage solution? It controls the cell swelling during hypothermia ischemia. There is a maintenance of intra and extracellular electrolyte gradient during the ischemia. Now comes the dynamic. Dynamic preservations could allow for organ optimization offering a platform for viability assessment and active organ repair and resuscitation. If you see, this is the future of preservation, where the organ optimization is there, where you see the viability assessment, you can do viability assessment also, and there is a repair and resuscitation also. And situ machine perfusion and in situ regional perfusion in the donor are emerging as the potential tools. So previously we used initially it was hypothermic machine perfusion, where the retrieved kidney is placed within the chamber filled with chilled preservation solution surrounded by an ice box. The renal artery is cannulated by one end of the tubing and the pump is used to generate a pulsatile or continuous flow of preservation solution they used to mimic in situ, and the fluid pours from the renal vein into the reservoir where the pump collects and again recirculated.
Thank you. Yeah, very good morning, respected chairpersons, respected faculty members, respected delegates, ladies and gentlemen. Yeah, at the outset, I must thank the organizing team for providing me the opportunity to speak on this topic, the optimization of branded organ donor in the ICU. This is pertinent with our theme, preserve organ and life. So we have taken this, and at least in Manipur, we have done at least 3 or 4 of deceased organ donation, and we have been so far successful, though it is in a very infantile stage compared to Sarnikuns and all, but we hope we will be doing more so. So as we go, the very sequence of the talks will be in this line. Firstly, on the pathological changes that occur in branded patients, followed by what we can do in the general care of the patient, then monitoring, then coming to the donor management goals, hemodynamic optimization, ventilation strategies, and treatment of the diabetes insipidus, which is the commonest problem there we find, then other hormonal therapies, and coming to the determination of which are the organs we can retrieve from the branded patient. So this is the actual things that occurs in a patient who goes into branded, the pathological changes. So when the neuronal tissues get damaged, there is cerebral edema, increase in the ICP, so the brain goes into transtentorial herniation, and the brainstem goes into ischemic changes, and so it releases lots of noradrenaline and other catecholamines into the bloodstream, and so heart gets the maximum burn initially. So the overall preload decreases, contractility decreases, so the overall output and the oxygen supply to the tissues decrease. In a similar way, the hypothalamus pituitary axis also get depressed, so many of the hormones are also decreased, catecholamines, the thyroid hormone, the adrenal insufficiency, everything occurs, and that also leads to decrease in the preload. And this is compounded by the usual use of mannitol, which we use for diuresis. On the other hand, again, hypothermia is very common because the metabolic rate decreases when the patient goes into death. The compensatory mechanism of vasoconstriction and shivering is not there. On the other side, the lungs is affected because there is pulmonary edema because of the cardiogenic or neurogenic causes, which also decreases oxygen supply. And there are other tachy or bradyarrhythmias because of ischemic changes in the tissues that produces acidosis and electrolyte imbalances. So in a nutshell, there is a lot of vicious cycle thing occurring in the body which leads to overall decreased oxygen supply to the tissues. So amongst these, besides the heart, the commonest is the deficiency of the vasopressin release from the brain. And so we have the arginine vasopressin deficiency to the tune of around 46 to 87% in the branded patients. And we should diagnose it in the background of branded whenever the urine output is more than 250 ml per hour for 2 to 4 hours at least, with low specificity or low osmolarity of the urine with hypernatremia most of the time. So in this background, when our patient is having all this problem, we have to optimize our patient in terms of correcting all these pathologies before we take up for organ donation. So at least in the ICU and as well as in the operation theater in continuity. So what are the things that we do in general is optimizing the intravascular volume, hemodynamics, and the normalizing electrolytes and the metabolic problems. And regarding the timing, how long we will take it? So around 48 hours is the maximum time if the patient goes into autonomic surge. That is, the patient goes into the cardiac activity decreases because of the extreme release of NORAD. But otherwise, we should shorten it as minimum as possible. Some studies have said 30 hours or less is preferable. Otherwise, patient may go into cardiac arrest before we retrieve the organs. So coming to the general care that we do, is with any other patient in the ICU, we continue with hand hygiene, central line, arterial line, police. Enteric feeding should be continued so as to maintain the glycogen supply. That's required, proper frequent suctioning, frequent body positioning, temperature to the normal usual, and the low molecular weight heparin should be continued.
It's already said about the ex vivo lung perfusion. This is the one outside the body. Lung was put in the chamber, and they just connect to your machines, and that goes around and that behave like a lung. So this gives the lung time to repair itself. So this is the way they do it. This is for the Western countries. As we got it from the Sanikun, in India, they have got 2 centers, now no one is doing. So whole thing about the machine perfusion is to maintain a metabolic activity by giving continuous supply of oxygen and nutrient to the preserved organ during the preservation period. So it has really revolutionized the way the organs are transplanted, because it provides a better graft quality and patient outcome. So it is good for assessment of the organ before transplanting to the patient. So some advantage of the machine perfusion over the static cold storage is that we can keep during ischemia. What happens? Anaerobic metabolisms causes the lactic acidosis, decreased pH, increased acidosis in the cell, causes the cell clumping, decreased protein synthesis, sodium pumps are failed, water retention was there, water influx was there, calcium influx was there. So this all causes the cell to die. So during reperfusion, again, your reactive oxygen substrates, they causes the cell to die. So to solve all this, yes, we all are talking about the temperature. From the first lecture till now, it's all about temperature, cooling down the body, cooling down the organs. So temperature is another thing to come on that. And the common solutions are for the organ preservative, OPS are the Collins, one of the pioneers, the first one in the thing. They are the first solution to create for the organ preservation. It has got like intracellular your component of the electrolyte was there. That means low sodium and high potassium. And afterwards, this was modified and better comes as a urocolins. And they're good for the solid organ. That's what about the first solution, which is very good that thing. Now comes your University of Wisconsin. It's still very popular here in India as well as abroad, and it's used for multiple organs like liver, kidney, lung, and like if you have to summarize what is the constituent of the University or UW's solution is, it is to prevent the cell edema, they put a raffinose or lactobionate, or to supplement the ATPs, they can put additional adenosines, then they put antioxidants like allopurinol and glutathione. So this is about your UW's solutions. Now the citrate solutions are there, which are good for the heart, and used for the kidney. Citrates are added to maintain the pH of the intracellular pH. So ISTK is another favorite, very common your solution used worldwide as well as in India. It has got histidine, mannitol, tryptophan, and alpha-glutaglutarate. And the electrolyte composition is low sodium, low potassium, low magnesium. So you have got Celsius. See, this is interesting. This solution is a combination of the ISTK and your EW solutions. The combination of that, which one is good, they just try to combine and make your solution. This is all about the Celsius. It's very good for the heart and the lung transplantation. Now we have got a IGL, which is got inverse composition compared to the EUW solution. Like we say in the EW, we have got lots of potassium and less sodium. But here, just opposite. Less potassium, more sodium. So this diagram says a comparison of all the things. See, if you see the electrolytes about the EW, sodium is around 125, 30, and potassium is around 125. And if you see the IGL, it's just opposite. 120 there, sodium, and potassium comes around 30s. And we put it colloids there. Then antioxidants are there, citrates are there for your citrates, nutrients, they put it, and so this is how they develop a OPS solution. And the blue thing are the one, the corrective measures. The red thing is the one which is affect the cells.
Very good morning. First of all, I'd like to thank the organizers for having me here today. My topic is informed consent, ensuring respect and autonomy. This will be discussed under these headings. First of all, let us find out what is informed consent. Informed consent is nothing but is just a process of communication between a doctor and his patient or a participant. And it is in this process the person will be giving his authorization to undergo a medical procedure or his permission to participate in a study. Informed consents are required in research as well as is required in healthcare services. So why do we need informed consent in healthcare and in research? It's because we need it to uphold the ethical morale. Second is, this is needed for the patient's safety, participant safety, and the satisfaction. Third is the legal aspects of it. Sometimes the doctor may be liable for negligence or battery if the informed consent process is not properly fulfilled. And of course, the regulatory requirements are there. Just going through the historical background of the informed consent. Informed consent in healthcare and research started well back in the before Christ. The Hippocratic Oath is something which mentions about informed consent. The Nuremberg Code, where the Nazi physicians, the doctors experimented without the consent of the prisoners of war. From therein came out the Nuremberg Code in 1947. Then the Declaration of Helsinki was formulated. Then the Belmont Report in America. And we have, and of course, landmark court cases are there, and we have our own ICMR guidelines, and then the CDESCO guidelines, and NMC Code of Conduct for dealing with our patients. So those are various guidelines wherein we see the informed consent process. Now, what are the domains of informed consent? Number one, the first domain is supplying information to the patient. This is first and foremost domain. Second is making the person understand. Third domain is taking permission from this person. Supplying information, how do we supply information? Inflammation is disclosing his condition, providing information in very clear, understandable manner, so that the patient or the participant understands the procedure, the entire thing, what is he suffering from, what procedure are you going to take up, then the alternatives to this procedure. If there are any alternatives, you have to give the alternatives to this patient. At the same time, you have to describe the risks and the benefits of such procedures for both the procedure alternative as well as the procedure that you are planning. So how much information is adequate? How much information is required to be given to a patient? Number one is reasonable physician standard. That is, the physician has to determine what information is appropriate. If you have to go on giving the entire process, the entire nitty-gritties of the, say, giving spinal anesthesia or general anesthesia, whatever, the patient may not understand everything. And he may be even scared also. So the doctor has to choose up to what extent reasonable standard. And he is supposed to know only what a typical patient would need to know is to be kept in our mind. And third is, sometimes the patient also you have to choose subjective standard. What would this particular patient, he may need to know. Patient, how much this patient requires to know, that is tailoring the information for that particular patient. Depending on that, you have to do. Making them understand is easy. You have to encourage them to ask questions. Whatever you're saying, you have to make them ask questions to him. Ensure his understanding. How do we ensure the patient's understanding is, whatever you have said, ask him to teach you back. Ask him to tell you back whatever you have said. I have understood, and I have also been told of my rights to refuse or withdraw anytime without any consequence. And fourthly, I am giving the permission to undergo this type of treatment on my free will without any coercion. So these are the wordings which should be there in any informed consent.
Next, I invite the next chairperson, Dr. Seni Posengpong, to receive the token of gratitude. Thank you, sir. Thank you, chairpersons. Professor Rajkumar Gojendra is a patron of Conference of Isacon 2024. He is also the professor and head of the Department Anesthesiology and Critical Care, Regional Institute of Medical Sciences, Imphal. Professor Nantombam Ratan Singh, he is a senior ISA member and he is the professor of Anesthesiology and Critical Care at the Regional Institute of Medical Sciences, Imphal.
Hello. Thank you very much. And a very good morning to all.
So, according to the latest definition of sepsis, sepsis 3, it is defined as a life-threatening organ dysfunction caused by dysregulated immune host response to infection. And septic shock is a subset of sepsis with profound circulatory and metabolic abnormalities with higher mortality rates. And it can be clinically identified with vasopressor requirement of to maintain a mean arterial pressure of 65 millimeters of mercury or more, and a serum lactate level of more than 2 millimoles per liter in absence of hypovolemia. So, what do we need to think about this? What are the critical aspects of management of septic shock? One of the most important aspect is early recognition, early hemodynamic resuscitation, early effective and timely source control, and the most important being stopping the resuscitation when physiologically sound targets have been obtained. So here we have to see that there is a fine balance between progressive hypoperfusion and over-resuscitation, both of which will paradoxically increase the rate of mortality. Today I'll be discussing with the following objectives: initial fluid resuscitation with the concept of optimal fluid management, intravenous fluid choices, vasopressor choices, and preferences and timing, then other adjuvant therapies, and what are the future targets and the research priorities we need to address. This is the latest Surviving Sepsis Campaign 2021 guidelines regarding the initial resuscitation. According to the guideline, it says that sepsis and septic shock are medical emergencies and they have to be treated as soon as possible or immediately. So what is the cornerstone of resuscitating a septic shock patient? So we'll see that optimal fluid management. Optimal fluid management becomes the cornerstone of resuscitation of a patient with septic shock. But how much fluid we are going to give and when to stop giving these fluids? What are the targets we need to achieve before stopping the resuscitation with fluids? All these questions need to be answered. So according to the Surviving Sepsis Campaign 2021, they recommend that 30 ml per kg IV crystalloids should be infused within the initial 3 hours of resuscitation. But after the 3 hours of initial resuscitation, how much fluid we are going to give? Whether we should use a restrictive fluid therapy or a liberal one, that needs to be answered. So many trials have been conducted, and the latest being the classic trial of 2022, which showed that there was no difference between the restrictive fluid therapy and standard fluid therapy. But how shall we guide this fluid therapy? According to this SSC 2021, they said that additional fluid therapy should be guided by the dynamic measures of fluid responsiveness. So what are these dynamic measures to measure the fluid responsiveness? And when should we stop giving these fluids? That means how much adequate fluid has to be given and when should we stop giving these fluids. This should be guided by the perfusion parameters. And now at this point we need to address that whether all these dynamic measures of fluid responsiveness and perfusion parameters are available in all the setups, or where mostly in the resource limited setups, what are the things we need to advocate. So what are the measures of which will predict the fluid responsiveness? We know that there are static measures as well as the dynamic measures. Although the SSC 2021 recommends using dynamic measures over the static ones, but these dynamic indices, they require high resources as well as expertise. Yesterday we have been taught about this echocardiography, the measurement of stroke volume and cardiac output and all those things, but all these setups, all this RG23 concluded that early vasopressors with restrictive fluid strategy did not significantly improve the outcome. So more multicentric powerful RCTs need to be conducted.
A very good morning, all the respected team members here and delegates and respected chairpersons. Today, I'll be speaking on a topic, a cardiogenic shock resuscitation, the best practice concept. All know that cardiogenic shock is a medical emergency caused by a primary cardiac insult, resulting in inadequate cardiac output, hypoperfusion, and organ injury. Also, according to the European Society of Cardiology, definition is cardiogenic shock, a syndrome due to the primary cardiac dysfunction resulting in an inadequate cardiac output, comprising a life-threatening state of tissue hypoperfusion, which can result in the multi-organ failure and death. Coming to the epidemiology, the cardiogenic shock complicates about 5 to 10% cases of the acute MI, higher incidence in women, age factor more than 75 years, and 50% of them 6 to 12 months of mortality over the past 2 decades. And survivors have about 18.6% risk of 30 days readmission. So the cardiovascular disease is a really burden today. In India, compared to the Western population, we have about 272 per lakh population, which is much higher than the global, about 235 per lakh. And 23% is the CBS dates around modern age before the age of 70 years in Western population, whereas it's, in India it is just 52, and the Western countries it's age of 70. So coming to the etiology, acute myocardial ischemia is being the most common, and others could be a mechanical defects, and we have a left ventricular outflow obstruction or inflow obstruction or contractibility defects like arrhythmias or pulmonary causes like pulmonary embolism or other cardiotoxic drugs, the doxorubicin, which is an anti-cancer drug. Then again, even the calcium and the beta blockers, if it is overdose, that could lead into the cardiogenic shock. So this is the pie chart showing the weightage of the etiology. It is acute coronary syndrome. It's about 60 to 80% here. So what are the factors for developing the development of the cardiology? So if the patient has a history of diabetes or any extensive damage of myocardium or age factor more than 70 or multiple vessel coronary artery disease, a prior diagnosis of the heart failure history is present, then chances of developing a cardiogenic shock is quite inevitable. So coming to the pathophysiology briefly, what happened is the ischemia of the myocardium causes depression of the myocardial contractibility, thereby a profound decrease in the cardiac output and hypotension, worsening the myocardial ischemia. But what happened is compensatory, body try to compensate it by activation of a sympathetic system, thereby increasing the afterload and tachycardia. But again, though in spite of increasing the coronary perfusion, that will worsen because of tachycardia, there will be myocardial oxygen demand will be increased. So this is again can worsen the ischemia. Then compensatory pathological vasodilators have been released to compensate it due to the systemic pathological vasodilatation, like mediators like interleukin-1, 6, tumor nucleating factors have been, or nitric oxide, peroxide nitrate worsens ischemia. So this is a self-perpetuating cycle which leads to global hypoperfusion and inability to effectively meet the metabolic demands of the tissues. So progressing to the multi-organ failure and eventually death. So next slide shows the systemic diagram where this is a viscous cycle. If you don't correct it on time in the beginning, in every level of the presentation of the patient, like we have to, otherwise it can lead to the cell death, and then finally the patient will be in the death. So this is, I won't explain, I will come to the only the, in the treatment part, I will again summarize it there. So according to the Society of Cardiovascular Angiography and Intervention, they have given a pyramid where it is from the base, you see the patients at risk. Patients have a cardiogenic shock who are not accurate and not currently expressing signs, symptoms, they won't know. For example, at the large acute myocardial infarction, prior infarction, then they start the beginning. The second stage, the patient has clinical evidence of relative hypotension or tachycardia without the hypoperfusion in this stage. Then the classic phase will come, including the presenting with hypoperfusion requiring the intervention beyond the volume resuscitation, like inotrope, pressor, mechanical support, include the ECMO. This patient is a classic presentation. Then the patient will deteriorate if you intervene it in this moment. A patient who fails to respond in the initial intervention, similar to the stage 3, then the extremes of the patients, we can see it. Then even here also, so they have categorized in the ABCD physical examination, biomarkers, and hemodynamics. Those first was a normal, everything was normal in a normotensive B patient, but even the cardiac index is more than 2.5, CBP 10, the saturation is maintaining properly. Then finally in the E stage, as the patient, if then systemic BP won't be resuscitated, a refractory BTBF can develop hypotension despite of the maximal inferred. So you have to intervene at the right time to just to control the ischemia or any coronary outflow should be try to be improved at every level of that treatment. So for suppose a patient comes, we have to evaluate. Before treating the patient, we need to evaluate. So what evaluation will do? So we take a brief history, like any predisposing history of diabetes-associated hypertension, hyperlipidemia, or any physical inactivity. Patient has been, because of a comorbid disease condition, patient has been unable to move, inability history is there, or history, familial history of coronary artery disease has to be ruled out. So this is a brief physical examination, like you have to see with the brain, pulmonary, renal, and the cardiovascular, skin. You have to be very quickly, you have to see all these organs has been, what is the defect in these organs.
The goal of assessment, whenever we are talking, we have to understand why we are doing a pre-anesthetic checkup, and that is going to guide us and what we do, how much we do. So we would like to identify the factors that significantly increase the risk of complications in that patient, and with that in mind, we modify the procedure appropriately to identify what anesthetic technique would be proper for that patient. Safety would be maintained for the perioperative period in this patient, and optimal utilization of resources, including unnecessary postponements. And all these will be done to ensure that there is improved outcomes and, very importantly, patient satisfaction when considering each patient as an individual and the person-related risk factors for the patient. Now, we can see that most of the time, the resident comes with a great smile. Sir, I've done the malam patti. And there's not even a record of any other thing, whether it is neck extension, etc. And then suddenly in the OT, they are found stuck. So the other thing is routine laboratory testing. Huge number of investigations. A patient is going to undergo a cholecystectomy. A normal, healthy person who was otherwise a housewife, doing work at home, everything including going to the market and coming. And they would talk about blood being requested, hemoglobin being tested, the chest X-ray being done, ECG being done. Now, why do we ask all of these things? Are they expected to modify our management of the patient? And if any investigation is done, is it going to be expected to be different, affecting our management in a sufficiently high number of patients with comorbid conditions that will impact it? If not, why are we doing? We say, sir, hamara desh mein everybody is having low hemoglobin. How much hemoglobin is low to affect our management? Is it 12? Is it 14? Is it 11, 10, 7? For a cholecystectomy, the hemoglobin loss, how much is needed? Well, if the patient is not actually looking pale, do they really need? If the patient was doing all physical activity and he was playing games, etc., why do we need a hemoglobin? Thank you. So we are saying that if they are not doing so, then it is not justified. How many abnormal results are expected? So, but if it was sufficiently high number, then it may be required, sir, if somebody goes to court. Otherwise, it does not. So, if the incidence of finding an abnormality is high, then, but the studies from across the globe, including India, are telling us that the detection rates from routine testing are extremely low. Sabko creatinine, why? Albumin, why? So we have all this, and an optimum PSC was mainly targeted to think that the perioperative morbidity and mortality would be reduced, but it also would reduce the unnecessary investigations and consultations. You get any ECG mild change. Now, why did you do the ECG in a 30-year-old person who was playing football, a 40-year-old person who was running marathons, a 50-year-old person doing all the work? So if there is nothing referable to that, and the physical examination, we have forgotten that history is important, physical examination is important. There is very little that the physical examination and the history will not tell us about the patient unless the patient is either belonging to the extremes of age. I am talking mostly for adult cases in this shortened scenario. And we will see that If the patient does not have any complaints, has not had any signs and symptoms which the history would tell us, why are we doing it? So this is where pre-anesthetic clinic defeats the very purpose. We get an X-ray done and we get a small positive a lesion somewhere. Now it is a double-edged sword. The patient was fine playing football, but you've got a small lesion. You see a slight opacity. If you have not referred it and something goes wrong later, now you are liable because it was not part of that. Yeah, now you have the lesion which was not affecting. But if it was there and you had not done an X-ray and it was not affecting the patient and it was a routine surgery, neither a lung surgery or anything, there was no need for that. But a case may need a consultation, may need further investigations, which itself might cause more harm to the patient. So the risk-benefit ratio of an angiography, of other studies, these and the expenses involved and the delays and the harassment, they are going to defeat it. Whenever I ask it, and sir, A is a grade 2 hazard. And then, okay, now have you told the patient what is the expected mortality, morbidity for that patient? Sorry. So he has no idea that with mild systemic disease it is 0.2%. And if it is severe systemic disease, it is 1.8. But with severe systemic disease, he is already hyper that this patient is going to die. And when the patient is moribund, sir, I have taken DOT consent. What is DOT consent when it is only 9.4? Now you say, sir, I have taken DOT consent, I am safe. Now I am going to become 70, I will be out of a job and I will just take a lawyer and sit outside the court, outside the college. And I will catch every patient coming out and tell, oh, they made these investigations. Why? Did they tell you this is the, okay, you can tell that you were distressed, etc., and you had a mental tension, the whole family was affected. They will file a case for you, against you for only these things. That you caused them suffering because you did not tell them. So all of these things, hemoglobin levels I mentioned, 7 gram hemoglobin. If nothing is there, you don't even need to give blood. So what is the anticipated blood loss? We don't do our job of trying to find out in each of our institutions, even we faculty have been working, what is the maximum surgical blood order schedule. The resident does not know. So if the person does not need any blood for that procedure and he is going about his daily activities and the operative procedure is not expected to cause bleeding, go for only grouping, maximum cross-matching. So these things in coagulation studies, again a new thing has come up. Sir, I am giving epidural, sir, and if there is a hematoma or this and that, history will tell us whether there is easy bruisability, whether he had occasions in which that in playing football his knee had become swollen and they had told him that he had bleeding into the knee. When somebody holds his hand very hard, suddenly they find it has become red because of this mild amount of bleeding. If there is no easy gum bleeding, nothing is there, why are we doing it? It does not give us. If it is 60,000, what will you do? 70,000, what will you do? Will you give platelets? So the recommendations are not there, but we carry on doing all that.
I would like to invite Dr. A. Jack Mayday, who is the Chairman, Reception Committee, 6th Isacon Northeast, to kindly come on the stage to felicitate our respected chairpersons. Thank you, sir.
There is a slight change in the schedules. We will be prepone our inaugurations program, and after that, our much awaited, valuable theme talks will be continued.
warm good afternoon to respected dignitaries, honored guests, and healthcare professionals present here. It is with great pleasure and immense pride that we stand before you today as we gather for the 6th Annual Conference of Indian Society of Regional Institute of Medical Sciences, Imphal, to the dais.
May I now welcome Professor J.V. Divatia, the President of Indian Society of Anesthesiologists, National Headquarters, to the dais. Sir, please.
Next, I invite Professor N. Sanjeev Singh, the Medical Superintendent of Regional Institute of Medical Sciences, Imphal, to 2024. Dr. S. Toibahenba Singh.
Next, I would like to welcome the Chairman of Reception Committee, 6th Isacon Northeast and 5th Annual Isacon Manipur 2024, Dr. A. Jack Mayperi, onto the dais. Sir, please.
Next, I invite onto the dais the Organizing Secretary of 6th Isacon Northeast, Dr. Yunnam Arun Kumar Singh, onto the dais. Request all the dignitaries to take your place on the dais.
Next, we would like to felicitate the honorable dignitaries on the dais for gracing us with their presence today. On behalf of 6th Isacon Northeast, we would like to extend our token of gratitude to Professor G. Sunil Kumar Sharma, the Director, Regional Institute of Medical Sciences, who is also the chief guest of today's function.
Next, I request Professor J.B. Divatia, the President of Indian Society of Anesthesiologists, National Headquarters, who is also the President of today's conference, to receive our token of gratitude.
Next, we would like to extend our token of gratitude to Professor N. Sanjeev Singh, the Medical Superintendent of Regional Institute of Medical Sciences.
Next, I would like to request Professor K. H. Maniram Singh, the State President of ISA Manipur, to receive our token of gratitude.
Next, we would like to extend our token of gratitude to the Organizing Chairman of 6th Isacon Northeast and 5th Annual Isacon Manipur 2024, Dr. S. Toibahenba Singh.
Next, we would like to extend our token of gratitude to the Chairman of Reception Committee, 6th Isacon Northeast and 5th Annual Isacon Manipur 2024, Dr. Asham Jack Mehtai.
Next, we would like to extend our token of gratitude to the Organizing Secretary of 6th Isacon Northeast, Dr. Yunnam Arun Kumar Singh.
Thank you, sir. Now, I would like to request Dr. Asham Jack Mehtai, the Chairman of Reception Committee, 6th Isacon Northeast, to kindly come to the podium to deliver the welcome address.
A very good afternoon to all. Distinguished guests on the dais, Professor G. Sunil Kumar Sharma, Director, Regional Institute of Medical Sciences, Imphal. Distinguished President of the program, Professor J.V. Divatia, President, ISA National Headquarters. Guests of honor in this inaugural function, Professor N. Sanjeev Singh, Medical Superintendent, Regional Institute of Medical Sciences, Hospital, Imphal. Professor K. H. Maniram Singh, President, ISA Manipur State Branch. Professor S. Toibahenba Singh, Organizing Chairperson of the conference. Dr. Y. Arun Kumar Singh, Organizing Secretary of the conference. All the speakers and resource persons, seniors, and my fellow ISA member, professors, and ISUD of different departments from various institutes, senior professors, fellow doctors, all the promoters and supporters, all the invitees, students, representatives from print and electronic media, all the volunteers, ladies and gentlemen. I, on behalf of the entire organizing team, and ISA Manipur State Chapter would like to welcome each one of you to the 6th Isacon NE and the 5th Annual Isacon Manipur 2024 here at Imphal, the capital city of Manipur. The theme of the conference is Preserve Organ, Preserve Life. It is my privilege and pleasure to welcome particularly our President, ISA National Headquarters, Professor J.V. Devitya, who has given a priceless contribution in shaping the ISA into a very healthy and stronger platform. We thank you, sir, for accepting our invitation to participate in this conference and sharing your exceptional knowledge and expertise in the field of anesthesiology during this conference. I also welcome Professor Prithvish Bhattacharya, former GC member of ISA National Headquarters and former director of NIGRIMS, Ceylon. I also would like to extend my warm welcome to our patrons, Professor P. Nishikanta Singh, former president ISA Manipur State Branch. I also like to welcome Professor Deval Singh, former ISA Secretary and President of the ISA Manipur State Branch. Let us seize this chance and make the most every second. I appreciate your presence and wish you all a nice and fruitful experience during our exchange of academic activities. Thank you very much. Jai Jai.
Now, I would like to welcome Dr. S. Toibahandra Singh, the organizing chairman of 6th Isacon Northeast, for the keynote address.
The theme, Preserve Life, Preserve Organ, Preserve Life. Actually, even though the state has entered into the transplantation era in the last 5 years, starting from Caesar hospitals and then Jenims, Manipur Government and Hospital entering into it. In the last 2 years, we started in June 18, 2022, and then we are not lagging behind. It may be kindly noted that with the available of the organ transplantation, it has changed the fate of many critically ill patients with end-stage organ disease. But the demand and the supply, there is a strong gap. And to overcome it in the developed countries and the Western countries, organs from the deceased donors have started very far ahead in the late 70s, but it has to yet reach this part of the country until very late. And we are not, even though late, we have entered into it on historic deceased organ donation on 2nd August 2023, and the deceased organ was procured at Jenims, and 1 kidney was transplanted in Caesar Hospital and the Jenims. And it marks to be the first of its kind in the entire northeastern region, and for the first time we have entered into the map of the deceased organ donation of the country. And we have not lagged behind. We were waiting for the beginning, and another 2 generous family members of deceased donor has already donated, so we have so far completed 3 deceased organ donation. But the figure here, even though per population our figure is very good, but the country, India itself, the availability of the deceased donor organ donation is very low. It is around 0.8% per million. Whereas in the developed countries like USA, it has already reached 25, and then Spain is at the maximum 32 deceased donation per million. So on the background of this, organizing this conference of Preserve Organ and Preserve Life happened to be very optimal, and because of the ensuing crisis, in spite of this limitation, the organizing committee was able to organize this conference, even though we could not attract much participants from outside the state because of the recent crisis. But I am still very thankful to those who believe us and who visited us, who are participating in it. And I hope this conference will enlighten us in our knowledge more on the theme, and we hope will perform well in the future also. And with these few words, I thank you once again. Thank you. Jai Hind.
We embark this journey as a gesture of auspicious beginnings. Let us officially inaugurate our conference by lighting the lamp. I request all esteemed dignitaries on the dais to please come forward for lighting the lamp.
Thanks to all the dignitaries on the dais for officially inaugurating our conference.
We would like to extend our heartfelt gratitude to everyone who has contributed to the creation of this souvenir.
Now, I would like to invite our Honorable Medical Superintendent, Professor N. Sanjeev Singh, to address the gathering.
I will not be able to talk much about anesthesia, as I'm not an anesthetist, but I know, being a surgeon, how important the role is, especially for a surgeon like us. The whole of the hospital basically runs on them. We are on the verge of starting our first kidney transplant and doing our first open heart surgery within the next month. And now these sort of workshops is going to play a big role, especially in these works. I'd like to thank Dr. Nipuns, who has been here with us and started training our anesthetists for the transplant-related works. Not much to talk about, but I would like to thank again the anesthetists, because we just fought COVID-19, and we knew the role the anesthetists played during the last 3 years. The whole hospital was fighting over one another that who will be going to theater, who will be going to the duty for COVID wards, but all the residents and consultants of anesthesia department were manning all the critical care cases without a word. Even the students, the residents, they were having so much of a duties, non-stop duties, 24 hours, 2-3 times a week without much complaint. I would like to thank all the anesthetists for all the work you have done, especially in the time of crisis.
Thank you so much, sir. Next, I request Professor K.H. Maniram Singh, the President of ISA Manipur State Branch, to kindly come and address the gathering.
It is our privilege to organize Isacon NE and Isacon Manipur at Regional Institute of Medical Sciences in Impal under the banner of Indian Society of Anesthesiologists, Manipur State Branch, with the theme of Preserve Organ and Preserve Life. I must sincerely thank Director Rims for giving moral and financial support to make this conference a grand success.
I'm personally very happy to be here in Manipur, and although you say you're a small state, and but I think you produce more medals won by individuals in the Olympic Games and international competitions. This is the land of Mary Kom, Mirabai Shanu, Kunjurani Devi, I mean, you can just name it, and I think between them they've won more individual medals than all other sort of medals that we've our athletes have won. So I think we are very proud to be in this state. So just a little bit about the Indian Society of Anesthesiologists. We are about 43,000 members. And of course, there are many who are not yet members of ISA. But like I say, ISA has something for all anesthesiologists at all stages of their career. So for those who are still postgraduates in anesthesia, they become associate life members, right? Then when they become full life members, of course, they become full life members. We have 5 themes sort of in this year, which are trying to push forward. One is, I call them the 5 Ps. So one is patient safety, and that I think is paramount. The second is professional excellence, right? So unless we are ourselves excellent in our work, we cannot be safe for our patients. So that's part of the same thing. And what do we do to provide for professional excellence? We have a number of webinars. So for PG students, every Monday, I don't know if you're aware, but every Monday, there is a postgraduate teaching activity on the web, online, right? And so that's this thing. Then we have, for practitioners, we've got every alternate week, we've got a series called Clip, and we've got a series called Crisp. Okay, so again, if you're members or in your groups, in your WhatsApp groups, you will get these sort of messages. So that's, for those who are inclined towards research, the editor-in-chief of the Indian Journal of Anesthesia has a series called REAP, Research and Publication in Anesthesia. So that is also an online series which comes every alternate week, I think every alternate Wednesday or Thursday. So you should be getting that information. When we coming to, of course, we have a national conference which is there in Patna this year, and I would invite you all to that meeting. So as far as professional well-being is concerned, we have a lot of dissatisfaction is there amongst many anesthesiologists, especially freelancers, about the payment that they make, the payment that they get. So I think all the city branches need to be very, very active and make sure that, that they stay united and they push for better working conditions and better payments and that sort of thing in their field. We also, every now and then we hear of a young anesthesiologist who's passed away and, who has died, and some tragic heart attacks and so on. And we all feel very sorry for those families, but I think we can do something very concrete for that. And one of the things that the ISA has is a Family Benevolent Fund, or the ISA FBF. And if for a small contribution that we pay at the time of joining, and couple of thousand rupees maybe every year, we can support the families of those anesthesiologists who so tragically passed away. So I think I would urge each and every one of you who's not a member of ISA to become a member, and for those who are members of ISA to join the Family Benevolent Fund, because I think that's a scheme by which we can offer concrete help to the families of our fellow anesthesiologists. Okay. We also have one P which now is becoming more and more important, and that is called planet safety. And so apart from patient safety, professional excellence, professional well-being, I think we are going to promote planet safety. And we are going to see how anesthesiologists can contribute to reduction in global emissions and global warming and so on. And that's going to be one of the themes that we will be sort of pushing for. Lastly, before I end, I would like all of you to remember the 6th P. And that is, please take pride in your profession. Take pride in what we can do. Take pride in what we have achieved and what we can achieve. I think we've shown the world, we've shown everyone what we can do in COVID. Please don't let them forget what contributions that anesthesiologists have made during COVID. But I think we can do much more, not only in the OR, but also in critical care, in pain management, and in general in the hospital's management that is there. For example, WHO says that it is a lack of anesthesiologists which is preventing simple basic healthcare from being provided in remote areas of our country. And they have 3 operations which you should be able to do. One is a laparoscopy.
We have seen the Department of Anesthesiology grown from, like in our UG time, it was sort of a simple sort of a department. By now, I think anesthesiology has grown above all the departments. So by now, they are the biggest and serving and also providing the biggest manpower and also bearing the biggest burden for the patient load. So that is First, my sort of heartfelt sort of gratitude and thanks to the Department of Anesthesiology for supporting the whole system. I think, in fact, today's medical science or medical field is solely dependent on one department, that is anesthesiology, that we can proudly say that one, and also be very proud of that. And from those days of single anesthesiology department, by now we have seen the cardiac anesthesiology, then neuro, then pain management, and whatnot. I think we have seen pediatric and obstetric gynecology sort of anesthesiology. When I was a student in a PG student at AIMS in 90s, we started hearing about like neuroanesthesia, cardiac anesthesiology. By now, standing here and even the RIMS, which is in a very far-flung place in the country, also start looking for specialized anesthesiology department. So I think the future is very bright for the Department of Anesthesia, and all should come forward to give the best to the society. As our President have talked about, we should be able to give at least the basic surgical, sort of whenever we go for a, other than the local anesthesia, we talk about regional anesthesiology and general anesthesia. There are lack of manpower here. We can, I was just talking with one NGO yesterday. We were providing some ICU facility throughout the country, especially after COVID. And the amount of, requirement for the anesthesia specialist is huge. So I think as a tertiary care center, we should be training the other, sort of even we can go for a short-term training where we can support the ICUs, where the life of the poor people can be saved. Let me come to the sort of little bit about the theme that we are talking about, the preserve organ and preserve life. And I was just reading an article yesterday about the sort of the number of organ donation that we are coming across. I came from South Isacon, so where we do have a organization, NOTO. NOTO is the biggest sort of organization who is looking after the organ transplant in our country. There is ICMR block in South Isacon, and the 4th floor there is one NOTO. Even though we hardly see any activity there, because if you look at the number, India, one of the, means by now we are the most populous country in the world, but I was checking the number. Last year, we had, last year was the year I think we crossed 1,000 disease organ transplant last year. Before that, it was less than 1,000. We can just imagine. And I was also checking the number of brain death. We're talking about the disease organ donation. I'm not talking about the live donation like kidney, liver that we are doing. But what is most important is about a disease organ donation, cadaveric donation, where the number was very minimal, like 1,000 in a population of like the number of road traffic accident death is close to about 1.5 lakhs per year.
It is with immense gratitude and profound sense of fulfillment that I stood before you today as the organizing secretary of the 6th Isacon Northeast and the 5th Isacon Manipur 2024 annual conference to extend my thanks and appreciation to all those who have contributed to the resounding success of these remarkable events. Our journey to the Isacon Northeast Manipur 2024, held at the Jubilee Hall, RIMS, Imphal, was not merely a gathering of mind, but a convergence of passion, dedication, and commitment towards a noble profession. With the resounding themes, preserve organ and preserve life, we embark on a collective mission to explore, educate, and elevate our understanding of anesthesiology in preserving life and enhancing patient care. First and foremost, I want to extend my deepest gratitude to our esteemed director, RIMS, Professor G. Sunil Kumar Sharma, whose presence graced our conference with encouragement and inspirations. Sir, your insightful address enlightened us and set a tone for an enriching discourse. I also would like to extend my sincere thanks to the ISA National President, Professor J.B. Tipatia, sir, for coming a long way from Mumbai to Imphal and grace the occasion as the president of today's function. I would also like to thank our medical superintendent, Professor N. Sanjeev Singh, for his unwavering support and encouragement in organizing this event. A heartfelt thanks to all the members of the organizing team whose tireless efforts and unwavering dedications has been the driving force behind the success of today's Isacon Northeast and Isacon Manipur 2024. From meticulous planning and seamless education, each member of the team has played a pivotal role in ensuring the smooth conduct of the conference. The commitment to excellence and teamwork has set a benchmark for future endeavors. I would also like to extend my gratitude to all the esteemed invited faculties and resource persons of today's function. Your expertise and dedication to the advancing field of anesthesiology has enriched our understanding and stimulated meaningful discussions. Furthermore, I would like to extend my heartfelt thanks to our sponsors and companies for the generous support, without which the conference would have not been possible. I would also like to express my profound gratitude to all the delegates, participants, and PG students who have joined us in this journey of learning and making this conference a truly memorable and enriching experience of all of us. I would also like to thank our great team, security team, Jubilee Hall staff, IT staffs, electrical staffs, volunteers, OT staffs, medical officers, MS office staffs for the who contributed significantly towards the success of this conference. In closing, I extend my best wishes to all for the continued success and fulfillment in all professional and personal endeavors. May we meet again soon, united by our shared passions for advancing the field of anesthesiology and preserving life. Thank you all. Long live ISC.
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Once again, we thank each and everyone present here for your presence. And here we conclude our official inaugural function.
To maintain the oxygen requirement of the tissues. And if we are not able to maintain adequate oxygen delivery to the tissues, then there will be hypoperfusion, and then that can result in organ dysfunction and organ failure. So we need to do something to do that. Right? And one of the ways in which we do it is fluid therapy, and we know that fluids are beneficial, but they can always also be harmful, and we need to have some way of making sure that you are giving the right amount of fluid to this patient. So what happens during major surgery? So there are two sort of types of responses. Right? One is what we call as the inflammatory response. Right? And this is what we talk about. And because of the inflammatory response, you've got vasodilatation, you've got increased capillary permeability. That causes fluid to leak out of the intravascular compartment into the interstitial space, and that produces hypovolemia. On the other hand, you've got an endocrine metabolic response, okay, and that actually is a release of ADH and renin-angiotensin aldosterone, and the purpose of that is to preserve fluid and to conserve fluid. Okay? And so you've got both these sort of responses which are happening. One is conserving fluid, and one is actually making the patient lose fluid. And depending on what is predominant, you'll either get hypovolemia or you'll get less hypovolemia. And depending on what you believe is the predominant mechanism, you will decide your fluid therapy. So many years ago, we had this theory which was very dominant, which was proposed by a fellow called Shires, and that was of the third space loss theory. And what he said is that when there is major surgery, we lose fluid. Of course, there is obvious loss of fluid, there is blood loss and evaporative loss and so on, but also there is loss of fluid into a space which he called as a third space, because he said even after you replace the plasma volume, there is still hypovolemia, and he said that you need to replace this third space fluid also, and that will then prevent hypovolemia. And the magnitude of the third space loss correlated with the severity of trauma or the severity of surgery. So the more major the operation, the more fluid may be required to make up for the losses in the third space. Right? And for many years, we used to believe that this was the proper way to do it, and that's why, at least when I was training, when I was doing my MD, we used to say for a hernia you don't need much fluid, but if you're doing a Whipple's operation or you're doing a portocable shunt, you need to give 8 ml per kilo per hour or 10 ml per kilo per hour as maintenance fluid just to make up for the third space loss. Now when people, for many years this was believed to be the God's truth, but when people started doing further investigation to the Shires theory, they found that maybe the third space is not as big as it was thought to be, or maybe it doesn't exist at all. And they did this by various they tried to repeat these experiments, they couldn't do it, but they said that maybe it's not as big as we think, it's unchanged or even increased extracellular fluid volume. So the implication of this is that if we were giving fluid as per Shires formula of large amounts of fluid, but the third space either did not exist or was actually very small, then all the fluid which we given is excessive. So we are actually causing fluid overload. We are giving excessive fluid based on a theory which was not exactly as true as we thought it was. So, and if we are giving fluid, excessive fluid based on that theory, then we are actually landing up giving too much fluid to the patient. And you can ask, so what if we give a little bit more fluid? So, but a lot of studies have shown that if you give excessive fluid, fluid overload is associated with worse postoperative outcomes. So it is not a benign thing. TK, fluid in here doesn't matter, we give some Lasix will come out. It doesn't work that way. And you can see that the mortality is clearly related to the amount of fluid that is given in excess. So as the amount of fluid excess or the increase in body weight keeps increasing, the mortality keeps increasing. So fluid excess is not benign. And we need to give the right amount of fluid so that we prevent hypovolemia, and we need to give the right amount of fluid to make sure we're not giving excessive fluid, because excessive fluid is harmful. Now, what do you mean by fluid overload? Now, commonly when we look at it in medical ward, fluid overload means pulmonary edema. Right? Now, even with our 10 ml per kilo or 12 ml per kilo, we've never produced pulmonary edema in our patients. So it's not just pulmonary edema. Right? There are many subtle changes which are occurring when you give excessive fluid. And this happens in many circulations, especially in the splanchnic circulation, for example.
Now I'd like to invite Dr. K. Raju Singh, the former Director, Manipur Health Services, to the stage to felicitate our respected chairpersons, Professor S. Toibahenba Singh and Professor L. Deban Singh. Thank you so much, sir.
beyond the sessions. Thank you.